CPR lessons from the past shaping our future. Does anyone recognize this face? Okay, well, this is the face of our famous CPR training mannequin, Resusci. Her story is about an unknown female cadaver who was found drowned in the Seine River, and an unnamed morgue attendant who made her a death mask, and he put it in the morgue window, hoping that someone would recognize her. Unfortunately, no one ever did, but her beautiful face and silent smile made it out of the morgue window and into souvenir shops, and today she has the most kissed face in human history. Autopsy after natural death is not routine. Not until the San Francisco Medical Examiner's Office decided to conduct a 3-year study on sudden cardiac death. The findings: 56% of the victims were truly of cardiac arrhythmic origin, 4% were of non-arrhythmic cardiac origin, and 40% were of non-sudden, non-cardiac origin. So 2/5 of sudden cardiac deaths were not even cardiac in this postmortem study. Throughout centuries of CPR practice, we used to beat them with nettles, and then we used bellows from the fire, and then we hung them upside down from trees to force the air out. And then when we didn't have any trees, we used wheelbarrows to force the air out. And when we didn't have any barrels, we used trotting horses, which is actually not so bad because we were passively compressing and ventilating at the same time. Then we had the fitness versions, and where we had good in with the good air, out with the bad, but there were no compressions whatsoever. And this continued through both world wars, except the victims were now turned over on their tummies, expand the chest at the air in, and then push the air out. By 1956, citizens volunteered to be paralyzed in order to prove that mouth-to-mouth breathing was better, and of course it was. And then defibs were invented, and finally educational programs were developed. This is Dr. Peter Safar. He combined the airway and breathing of CPR with the chest compressions. He wrote the book ABC of Resuscitation in 1957. He established the basis for CPR mass training, and he even convinced Norwegian doll maker Asmund Laerdal to design and manufacture mannequins for CPR training, and guess what? Yes, they were all Resuscians. All of this was not adopted by the American Heart Association until 1973. So, by 1995, the guidelines had the ABCs of CPR becoming ABCD, where the differential diagnosis was added. Our compression rates were now to be between 80 to 100, and we used AEDs. By 2000, we had 3 stacks of electrical shocks up to 3 sets. We had compression rates becoming 100 per minute for adults. We had ventilation ratios of 15 to 2, and the guidelines in 2000 placed their focus on foreign body airway obstruction and choking. By 2005, the compression rates were now to exceed 100 per minute, and we were to begin compressions before shocking. By 2010, with the advent of modern technology, we were to immediately contact EMS and initiate CPR, and our ABCs changed to CAB because they realized that initially there's enough oxygen in the blood to go, plus the compressions yield passive ventilation, provided that you have a maintenance of a patent airway. By 2015, chest compressions took on the greater focus. We created community-led rescue AD programs, and we recommended naloxone administration for opioid toxicity. So, what you see in front of you is the post-cardiac arrest care highlights of the updated 2015 guidelines. Let's have a look. Alright, emergency coronary angiography is now recommended for all patients with ST segment elevation, as well as for hemodynamically or electrically unstable patients without ST elevation, purely on suspicion. Target temperature management, range of temperature is now recommended because they found that 36 degrees centigrade is just as good as 34, provided that we maintain a constant temperature. Fever. Alright, fever is a natural body defense mechanism, okay? So there's no surprise here that they had conflicting observational data about its harm. Hypertension, of course, needs to be addressed. We need to maintain the renal output above 1 milliliter per kg per hour. Prognostication, not to be done before 3 days. And once you announce your victim to be brain or circulatory dead, then you need to really consider them for potential organ donation. Okay, recognize this. This is the chart. We all have this memorized by heart, and we encourage our students to do the same. Start CPR, diagnose, shock, CPR, shock, CPR and adrenaline, shock, CPR and Amiodarone. Okay, then now let's have a look at the 2018 focused update on ACLS use of antiarrhythmic drugs. This is by the American Heart Association. And actually they're being very candid about this, and they're now telling us that it is unclear whether these medications improve patient outcomes. They're telling us that available studies do not demonstrate any improvement in survival to hospital discharge with either Amiodarone or Lidocaine. They're telling us that, as noted in earlier guidelines, CPR and defibrillation are the only therapies associated with improved survival. They're telling us the optimal sequence of ACLS interventions, including the administration of a vasopressor or antiarrhythmic drugs, and the timing of medication administration in relation to shock delivery is not fully known. So basically, what they are telling us is that this chart is based purely on expert consensus. So since 1957, the only evidence-based techniques in BLS and ACLS have been the compressions, and the defibrillation. The only evidence-based techniques in BLS and ACLS are the compressions and the defibrillation. So, what's the story behind adrenaline? Well, there have been 9 trials done on adrenaline, and 7 of them proven to be harmful. So much so, they decided to conduct the Paramedic 2 trial, where they compared adrenaline to placebo, and the results were out just last year. Okay? Adrenaline in cardiac arrest results in less than 1% more people leaving the hospital alive, but nearly doubles the survivor's risk of severe brain damage. What's the story with Amiodarone? Not a happy ending either, because there is no benefit of Amiodarone in survival to discharge or neurological outcomes compared to placebo or other antiarrhythmics. So basically you're back to square one. And this is actually quite nice because the HA now has self-training kiosks teaching proper compressions. And we now know that hands-only CPR in the first few minutes is just as effective. Okay? And the technique is really easy to master. It's so easy, we can practically teach anyone to do it. Meanwhile, on the other side of the planet, in South Korea, they have really tiny elevators, and the only way you're going to fit inside is either heads up or heads down. So they had to conduct several studies, and they found that the most optimum position was a 30-degree heads up, because there was a lower pressure in the head and thorax, and it yielded higher cerebral perfusion pressure. Now this is my favorite. It's a non-invasive, radiation-free, acoustic-based system, which has been validated clinically to rule out coronary artery disease in less than 10 minutes with 96 to 97% negative predictive value. This is the CAT scoring system, and it was introduced at the European Society of Cardiology in 2018. Now this is something to really keep an eye out for. And we have Ohio State University introducing an ECMO protocol en route to the cath lab, and according to them, their survival rates rose from 0 to nearly 40%. The hand-free systems, of course, compressions without hands, that's extreme, because hands-free you can transport your patients, hands-free you can hook them up to the ventilator, hands-free you can perform coronary angiography. The only drawback is that this takes a lot of practice to perfect the skills of using it. You now have flying AED drones, We have flying ambulance drones. And let's not forget about the more beautiful half of the population. Women. Typical chest pain? 43% of them don't even have chest pain. Alright? They'll present with fatigue, neck pain, and headaches. And to make things even worse, bystanders are uncomfortable touching women, so they're less likely to even receive CPR in the first place. Okay, now back in time, a couple of years back, I thought that if we can control the functionality of the sodium-potassium pump, then we can rewrite the CPR guidelines and the cardiac arrest guidelines. But sadly enough, cats were predicting death better than we were, simply by sniffing out our cadavering and putrescine. We're so imprisoned behind our ECG, we need to start thinking out of the box, because no amount of CPR is going to bring this fish back to life. It either should have been taken out of the water, or it should be put back in the water promptly. There's so much beauty in nature, and we need to start thinking in terms of beauty in order to truly understand. For example, the Fibonacci sequence. It's not present just on the outside, okay? It's literally beating in our own heart. Fibonacci sequence is present in the coronary arteries, okay? 2, 3, 5, 8, 13, 2, LCA, RCA, 3, LAD, left circ, RCA, and so on. This is the age of quantum science, and chemistry world are now calling to bring quantum tunneling to the table when trying to understand chemical reactions. I think it's high time that we started to bring quantum biology to the table as well. And this is just another example. Electromagnetic frequencies. They have all of these effects in our bodies. We've managed to harness electricity for the DC. I'm pretty sure we can use this EMF to our advantage and turn this into a good cup. Okay? So my take-home message is that we desperately need to add physics, math, geometry, light, and sound into the medical equation, and we need to focus on prophylaxis. Thank you. I hope that made sense.